Okay, good afternoon everybody. I think we'll make a start. My name is Lana Glagoski. I'm the CEO of Palliative Care WA. Thank you very much for coming to our sector forum on goals of patient care. Just some very quick housekeeping. Could I ask you if you've got phones to please turn them off or turn them on silent? Because we are recording this session and we don't want phones going off. So welcome and thank you so much for coming. I would like to acknowledge the Whadjuk people of the Noongar Nation and who are the traditional custodians of this land. I would also like to pay respects to elders past, present and emerging and extend that respect to other Aboriginal people present at this gathering. Now, please be advised that we are recording this session this afternoon to edit into an educational video for use by WA Health and to upload to our website. People who are in attendance in this room have signed a release form indicating that they are willing to have their image used in the filming. So can I just let you know we've got about 20 people online via Zoom. So to those people, we ask that should you not want your image to be visible in our recording, we ask you to do one of two things. Either turn off the video functionality on your screen so that we can't see you. And secondly, if you don't want your name to be seen, can you please change your username sign-in by going to the top right-hand corner of your screen where you'll see three dots. Click on the three dots. You will then see an option to rename. Click that option and then put in whatever detail you would like, such as simply participant. If you don't have any concerns about your beautiful image potentially being used on this recording, then you don't need to do anything. Okay, so today we're talking about goals of patient care and we are very privileged to have Simon Towler presenting for us this afternoon. So we've got an hour and a half, so basically Simon has got an hour to present. And then we'll have a half an hour of questions after his presentation. So people online, you will have the opportunity to use the chat function and share your questions with us. People who are in the room obviously will be able to put their hand up and ask those questions. So introducing Simon. He's a staff specialist in intensive care at Fiona Stanley. He was medical co-director during the commissioning of the hospital before being appointed as the clinical lead to the Futures program in the South Metro Health Service. Prior to this, he worked at Royal Perth Hospital for 25 years in intensive care, including a period of head of department and director of the Division of Critical Care. He was also WA's Chief Medical Officer from 2008 until April 2012. In late 2018, he was appointed to the Ministerial Expert Panel for the development of the voluntary assisted dying legislation in WA. From his personal experience of being a patient with a life-threatening illness, Simon has gained a much deeper appreciation of the challenges that patients face and the importance of a true patient-focused approach to the delivery of health services and health care. So can we give Simon a very warm welcome? Simon.
Thank you, Lana. I'm a bit embarrassed to be listening to that bio. I think we should update it. I will add one thing to the introduction after also taking this opportunity to acknowledge the traditional landowners on the land on which we meet and to really think about them in terms of the conversations we're about to have and some of the particular challenges for Indigenous people and those from cold communities as well. Lana's given you an outline bio of which is all correct, but it's slightly out of date. And I hadn't thought to send an updated one. And the additional information that I think is worth telling you is that early this year, I was appointed, having left the Futures role at South Metropolitan Health Service, to the position of clinical lead with the Cancer and Palliative Care Network in the domain of end-of-life care, which in fact is largely what I'm doing here today. We'll talk a bit more about some of the other things we've been up to, and my colleague Valerie Colgan, who's in the room, has been an important part of some national work we've been doing, which has been presented here before, about the partnership between Western Australia and the Australian Digital Health Agency, who provide the My Health Record capability. But we've been doing quite a lot of work in this particular space. So I want to thank my colleagues for their contribution. I want you to also be aware that this is very much part of the role that I've taken on more recently as clinical lead for end-of-life care. Could declare a few other conflicts of interest. It's nice to be in the room. Was appointed late last year as a board member of Palliative Care WA. I'm very pleased to be involved in that, and have found it really most stimulating being involved with that group of people and thinking about, at this time, all the extraordinary things that have actually come out of this very thick document. Most of you would recognise it. This is the My Life, My Choice report. Excellent bedtime reading, 608 pages. I can absolutely recommend you look at it. Palliative Care WA did a really good job. They were producing a little summary document. I think it's very important to understand that in Western Australia at the moment, there is a very comprehensive discussion going on about all aspects of managing people with advanced disease or late in their lives to really improve what we're providing to people, giving them better options, giving them greater choice. I think you would have had to have been somewhere else in the world not to have been here in late 2019 whilst the voluntary assisted dying debate was going through the Western Australian Parliament. In fact, if you wanted to go and sit in the gallery, it was very entertaining and went on for quite a long time. Western Australia became the second state in Australia to really proclaim that we would make voluntary assisted dying available, and that will happen in the middle of next year in terms of it actually being directly available. And it was the thing that really got the dominant publicity. But the other things in this report were also extremely important. There's been substantial work around looking at and improving palliative care services. The government made a substantial additional investment and continues to look at how we can improve palliative care services. And I won't be talking about that today, but it is part of a package. It would not be appropriate for us to be talking about one of those things in isolation. And the third body of work in the My Life, My Choice report was very much about planning processes. People in this room will be familiar with the idea of advanced care planning. They're probably familiar with the idea of what is an advanced care directive or an advanced health directive, which is a written instrument in most cases. And what people don't seem to be nearly as familiar with is in fact the concept of goals of patient care forms. And that actually became quite a conversation during the public submissions and public hearings for the work around the My Life, My Choice report, where it was clear that not only were consumers and patients confused about goals of patient care forms, but so were the doctors, which is a bit concerning. So what I'm going to try and do today is come at it from a very different direction. I'm going to come at it from what is known as the National Safety and Quality Health Service Standards. And that's because the goals of care form is a form that applies to making a decision around care planning when you're in a hospital or other health service and looking to what kind of care you would wish to have in the context of that admission and potentially in related admissions after you leave the hospital. It is in that sense starting from the hospital end, not starting from the conversation that occurs in the community, which we encourage everybody to initiate well in advance of finding themselves in the setting of needing treatment or healthcare, and particularly if it's emergent. If you end up in the emergency department, your wishes are unknown, then the clinicians have a fundamental responsibility to provide you with care to try and preserve your life and get you to overcome your illness. So that's kind of where we're going to start from. And this is particularly pertinent because in the same period of time that we had those conversations going on with the My Life, My Choice report, the National Hospital Health Service Standards transitioned from what was called version 1 to version 2. And I'm going to lead you a little bit through the information and thinking that's in the national standards to come to this point around you having a clear understanding of what the goals of care, goals of patient care process is actually made up of and what it constitutes. And I'm very happy if anybody in the room, it's much easier to work to the people in the room. I'm very glad there are some people in the room. It's very hard talking to the Zoom camera when you've got an empty room. But if you wish to interrupt or you want some clarification during the process, I'm very happy to stop and to try and explain things if you are at all confused or uncertain. This is where it always happens that it won't go forward. I'll get somebody to come and help me with this. Do you want to see if that can be made to work? I'm just pushing the forward button, but nothing's happening. So, the National Safety and Quality Health Service Standards have come out of a whole body of work done in all states in Australia and sponsored by the Commonwealth Government. And the agency that does this work is the Australian Commission for Safety and Quality in Healthcare. The fundamental idea behind having the Commission, and Australia is one of the countries where there is a national body looking at the quality of health services and the quality of the care that they deliver. And in fact, it's a really important domain for all of us to think about because in all of the health services, and particularly those run, well, in fact, all hospitals, if you do not get accredited and pass your accreditation under these standards, that is considered to be a significant deficiency. And in fact, if you go to any hospital in WA, you will find the accreditation certificate, usually issued by the Australian ACHS, Australian College for Health Service Standards, Commission for Health Service Standards, who make the assessments to tell you that this hospital has undergone an evaluation of its processes against these national standards. And very importantly, in the transition from the first version of the standards to the second one, this idea has become really very central. That after 40 years of growing recognition and acceptance, consumer partnerships in healthcare are now viewed as integral to the development, implementation and evaluation of health policies, but also clinical programs and clinical services. And the patient and consumer partnerships are also a pillar of the idea of person-centred care. That is, that care focuses on the relationship between a patient and a clinician and recognises that trust, mutual respect and sharing of knowledge are needed for the best health outcomes. It is a lofty goal. And part of the challenge I find is that this is not people's routine experience. So we're going to have a little look at what has been the emergence of this goals of care concept. So what is a goals of care process? And this comes from some important work commissioned by the Australian Commission for Safety and Quality in Healthcare, which is goals of care are clinical and other goals for a patient's episode of care, in other words, a treatment time period, that are determined in the context of a shared decision-making process. So if you're doing an advanced care plan or you're doing an advanced health directive, your own personal document that outlines your beliefs, values and preferences for care, often you may choose to do some preliminary work on your own. You may take advice from a doctor, which I strongly recommend, even though it's not required, because you're setting up decision making around what treatments I will agree to or consent to, and what treatments I may not wish to consent to, or with those which I might refuse. When you end up in hospital, we need to do something around ensuring the care you receive is focused around those values. So what I want to point out from the outset is this activity is not in opposition at all to an advanced care planning process, and in fact if both of them exist together, then the outcome for the patient is by far going to be focused on their wishes and the treatment decisions are going to be of higher quality. So these are the new National Safety and Quality Health Service Standards, the second edition. I'm just going to point to the two important ones. There are 8 standards, and we're not going to look at all the others. But there are 2 absolutely critical ones. One is the idea of partnering with consumers. Now, in the old standards, the hospitals would establish committees for each standard. They would put in place a plan. They would be assessed against the individual standards, and the relationship between the different standards was really not deeply assessed. In the new version, everybody is required to demonstrate this one, which is what we call clinical governance, but the consumer participation, it has to be evident how it applies across the range of standards. Things like blood transfusion, recognising a deteriorating patient, the quality of clinical handover, medication safety, and avoiding hospital infection. And it's not good enough any longer to just have a good plan for each one. But this one here, this is the real change. This is a new standard in Australia called comprehensive care. And a lot of work went into this by the Australian Commission, and I'll show you some of the background research which was conducted by the Sachs Institute in Sydney, demonstrating that this comprehensive approach to delivery of care is an important foundational piece for the quality of care which you deliver. And you might have already worked out that very central to this process is going to be this goal-setting, shared decision-making concept, which actually sits behind the goals of care process and is very similar to the way we would hope that an advanced care plan or an advanced health directive is taken up if you present to hospital for treatment. So, partnering with consumers, very central focus on mutual respect, acknowledging the patient's wishes, and then developing processes in partnership with the patient to determine and support you to identify your goals for care and what are the value statements that exist around it. So, what do we know about it? Partnering with consumers, which describes the systems and strategies to create a person-centred health system by including patients in shared decision-making. It is the cornerstone. If you're going to have a quality health system, then you want this phenomenon of shared decision-making. And we'll come back to talking a little bit about the fact that some clinical staff find this process quite challenging. And you'll often find that, if particularly around an end-of-life care conversation, they find it even more challenging. But they're usually challenged because they think the patients don't want to have that conversation. Well, in fact, in some of the research work, it is very clear that many more of the patients are very happy to have that conversation as long as the opportunity arises. The patients need to be partners in their own care, and the consumers are involved in the development and design of quality healthcare services and in relation to their own particular care delivery. So, was this a good thing to do? Well, we like to work on an evidence basis. And the Commission actually welcomed the Sachs Institute from Sydney to do a very substantial piece of work to actually work out whether there was any evidence that this approach, a comprehensive care approach based on shared decision making and goal setting, actually made any difference to anything. I'm sure you're going to work out that they found something to support it. So that's not going to be a big surprise. So what did they find? Comprehensive care, as it was defined, had these 2 elements. It had involved the intentions that include patient-centred care and goal-directed care. Now, it is common when you encounter a clinician who's going to offer you a service or an intervention that the goals of care will be framed around the idea of the treatment will improve your clinical outcome. And in many cases, that will in fact be achieved. But sometimes there is a need to have the patient understand also what that pathway looks like and what the experience is going to be. And that the true goal-directed and patient-centred care must be around the sharing of information, to result in a shared decision process that explicitly includes patient preferences and goal setting in developing your individual care plan. So the heart of the comprehensive care standard, which goes to this very issue of goals of patient care, is a shared process to develop a patient-orientated specific care plan which is essentially tailored to your needs. Now, I work in intensive care units. I look after a lot of patients who've undergone major cardiac surgery. I often now talk to the patients who are doing well afterwards. What did you expect? What was your experience? Has what you've experienced been anything like you imagined it would be? And often they'll say, well, not really, or that tube down my throat, I really didn't expect that and it's really horrible. Or, no, the ICU staff are fantastic. It's very sore and painful, but I'm absolutely confident we're going to get there and it's a really good thing to have done. And I say, well, did we also talk about what if you were one of the people where this didn't go well? I said, well, they gave me a long list of issues to look at, and I realised there were risks and I might die and I might have a stroke and I might have this and that. I said, well, was there a conversation about what would you want if you were the one person who actually didn't survive the operation? What would you want if you were the one person in 100 who has a stroke complicating major heart surgery? Have we got an idea about your aspirations for that kind of care? And you can see immediately that this work relates very closely to the idea of patient consent for treatment. And suddenly you can see also how it relates back to the idea of advanced planning and advanced health directives. So what else do we go on? Well, it is not surprising that they found that in the published literature, after a very extensive review, that if you have a comprehensive care model, patient satisfaction, interesting things that hospital administrators quite like length of stay, costs of care, acute care readmissions, and in fact now hospitals are penalised if you have too many of these things, will most frequently measure outcomes in relation to comprehensive care interventions. Older patients were the most investigated group in the literature, and that relates us back to the goals of care concept in end-of-life care. But in the work, 80% of studies resulted in a reduced length of stay. Cost of care was reduced in nearly 86% of cases. Readmission rates were declined in 50% of the studies, but most importantly, patient satisfaction increased significantly in 60% of the studies. And shared decision-making goals of care increased significantly in 100% of studies investigating these outcomes. So in other words, in those people who were researching this activity, the behaviours that were seen amongst the clinical staff resulted in a substantial improvement in a goal-setting shared decision-making process. And it results in overall improvements in health services, and there's evidence of moderate to high methodological quality in most of the studies which were examined. So, significant increases in the frequency of patient involvement in goals of care discussion and of shared decision making was found in the application of comprehensive care by 3 important studies, found significant increases in communication with health professionals after the intervention. So the culture around this, the idea of the discussion between patient and clinician, is robustly evidenced, and it's a little surprising we therefore struggle to actually make this work on a consistent basis. And here it is. I mean, if you're into evidence-based processes, this is the grade process for levels of evidence. The final recommendation from the Sachs Institute review was very clear evidence that implementation of a comprehensive care approach, particularly for older adults, can improve patient satisfaction, all these other elements we already discussed. And at the organisational level, the organisation should consider aspects of upskilling staff, embedding comprehensive care into ongoing quality improvement. And at the unit level, the goal of comprehensive care needs to be established appropriate team structures and a mode of delivery. So it's going to be really important for you as consumers and users of the health system to really request this kind of behaviour, to really seek it out and to support it wherever it's possible, because these are very substantial evidence levels. So, where are we going with this? So, on the back of the Sachs Institute review, the National Hospital and Health Service Standards implemented the Comprehensive Care Standard now as a critical framework for the performance of hospitals and services in delivery of care. And very importantly, and not surprisingly, focuses on care that is centred on patient goals and patient well-being. This is now fundamental to a quality health service model and improves quality outcomes, improves patient safety, and certainly results in better patient satisfaction. And within Comprehensive Care Standard, and very importantly for this discussion, Action 5, which the standard's number 5, Action 20, clinicians should support patients, carers and families to make shared decisions about end-of-life care in accordance with what is known as the National Consensus Statement, the essential elements for safe and high-quality end-of-life care. Now, who knows about the Consensus Statement? Is anybody aware of it? A couple of people. Valerie knows because I've been beating her to death with it. And you may not be surprised that within the National Consensus Statement and the essential elements for safe and high-quality end-of-life care, number 3 element in that framework is in fact that there should be a goal setting and patient shared decision-making process around end-of-life care. And in fact, in the national project that we've been leading on looking at how you might include goals of care information in the My Health Record along with advanced care directives and advanced healthcare plans, it has become very clear that this is an important element to share the information that comes from that process. So who can tell me what proportion of Western Australians have an advanced health directive? Valerie's going to tell us because we've been looking at it. Pardon? About 7%. Now, we had a very interesting meeting looking at advanced health directives yesterday with a very engaged audience. And I would obviously say, or I would say to you that for many people in our community who are not currently unwell, who do not have an illness, who are not facing some kind of decision around care planning or end-of-life care or frailty or anything else, actually writing an effective advanced health directive is extremely difficult. You can put some general terms up. You might want to write down if Lana's favourite story of the poor Metropolitan Transit bus that has now killed about 100 people in Lana's presentations. We could write an advanced health directive about what you might want if you were the victim of a catastrophic event. And that would be quite reasonable. But for many people, actually writing down something specific around treatment you may want or not want is extremely difficult if the treatment issues are not something that is of concern to you currently. But the other important part of those documents is writing down your values, your beliefs and your preferences. And I think over our life we become to a greater and greater understanding of what we think about those things. And certainly for me, and was mentioned in my bio, I had the misfortune of being diagnosed with cancer in 2012, which was a pretty nasty wake-up call in my late 50s. I had the Michael Douglas disease, the squamous cell cancer in the neck from the human papillomavirus. Unfortunately for me, the outcome for that condition, if it's picked up early, is pretty good, 85% cure. Reminding everybody that cure in cancer literature means you survive for 5 years. And now I'm 8 years post-diagnosis. There's not really a lot of information about what to expect, and we'll come back to that. So that, of course, precipitated a really interesting discussion for me about, well, what do I really want? Now, having been an intensive care doctor at that point for the best part of a quarter of a century, I'd seen a lot of people who had severe misfortune. I'd seen a lot of people where families found themselves trying to make decisions on behalf of a loved one with no framework in which to do it, and often with disagreement between family members and lack of clarity. So making a statement about your values and preferences, making a choice about who I nominate to be my decision maker, are really important things that you can do even if you don't have a life-threatening condition. And when you go to hospital, when you get into this environment now where we're talking about comprehensive care and we want to engage with you in a goal-setting process, then that information is extremely valuable. Now, none of the instruments we've talked about actually have any application, or in technical terms, any jurisdiction. If you're sitting there, you're completely with it and you have capacity to make your own decision, because it's still you and your decision making. But most of these things have two elements. If you've thought about your values and preferences, then the questions you might want to ask and the orientation around what I might expect from my treatment is informed because you've thought about it in advance. And if in the situation where somebody else has to make a decision, there's very clear kind of boundaries for the decisions to be made. And if you have appointed an enduring guardian and you've had the conversation with them, then they will be in a better position to make a decision which is consistent with what you want. Now, in this goal setting process, the first questions we ask in a goals of care process is, do you have an advanced care plan? Do you have an advanced health directive? And have you appointed an enduring guardian? Because when you get to the hospital and we're putting a planning process in place, that information is absolutely fundamental and forms a critical part of this high quality approach to planning as you approach end of life care.
Excuse me.
Yeah, please. Yeah.
What's the difference? I've got advanced I've got an advanced health directive, but I haven't got the plan. Can you tell me the difference?
Right, three things here. Firstly, let's talk about an advanced care planning process. That is the exercise you go through, often and hopefully with assistance, often with a family member, which is where you talk through, think about your wishes and preferences. If you have a condition and you know that you face certain things going forward, you make some decisions around what care you might or might not want. That's the process. The advanced care plan is documenting those things. You can document an advanced care plan on the excellent form the Palliative Care WA will provide. You can write an advanced care plan on a computer and print it out. It is a statement of wishes, and it may include statements around treatment options that you may wish to have or not have. At common law, it is recognised by the clinician. But the Advanced Health Directive is a term reserved for the document, the statutory document, in other words, the document defined by the legislation and found in the regulations for the legislation, which in our state is the Guardianship and Administration Act, which if you write that information into that form, it has a particular influence by statute. And in fact, in this state, if you've completed an Advanced Health Directive and it is completed properly, it in fact is the number one decision-making tool when you cannot make the decision. But as we spoke about yesterday at quite some length, what you write in the form needs to be able to describe the clinical circumstance in which the clinician finds themselves looking after you. So the only difference really is one's a statutory document and one's not statutory but still has influence. Interestingly, and I'll talk in a little while about what's called the National Advanced Care Directives Framework, they are now talking a little bit about advanced care plans for people who don't have capacity. In other words, we are concerned that their ability to understand all the issues is limited. They may not be able to discern and make a decision about the consequences of their decision, but they can, in a conversation with people, write some kind of plan that we all agree to. That is not a traditional advanced care plan. In fact, it's much closer to a goals of care plan, which I'll explain in a minute. But your advanced care plan is completely legitimate. It has legal influence through common law and should be taken into account, which is why when you go to hospital, we ask whether you have one of those, because that's helping us to have a goals of care discussion. But if you have an advanced health directive, the hospital really needs to know, because in fact they're supposed to be making an effort to find out if you've got one. And if you've got one, they're meant to be following the instructions in that form, because that form is you speaking and giving consent or refusal.
I don't think that's quite reached that stage. I took one to the hospital and I what's this?
Well,
Sorry.
we had an interesting conversation yesterday about some clinical responses to being presented with a legitimate advanced health directive, and there is no question, and partly why I've started with the national standards, is because the hospitals cannot hide anymore. And I'm going to come back a little more to the provisions under the national standards. But if you take an advanced health directive to a hospital now, the people who assess the hospital's performance are in fact going to look at, does the hospital have a system to receive your form? Does the hospital have a system to store your form? And does the hospital have a system so the clinician who suddenly finds themselves looking after you can find the form? I'm going to come back to this in quite some emphasis as we get a little bit further into the talk, because at that point it will be important to understand that these processes are partnering. And what I'm going to say, and the reason I asked about how many people have one of these things, is because if you recognise that every year 1 million people present to the health emergency departments in this state, that we admit about 320,000 people to hospital for some kind of procedure, and that's not including the private sector, that every one of those people goes into a healthcare environment, a very substantial proportion of them actually have an occasion of having no capacity. What's it called? Anaesthesia. Anybody had an operation recently? Because when you're asleep, you have no capacity. I mean, none. So in almost every major hospital intervention where sedation or anaesthesia is used, there is a period where you are without capacity, and these things actually take effect. And very few people talk about that. And I have the misfortune of looking after people whose operations don't go very well, end up in the ICU, and suddenly I'm saying, well, what are we doing? Oh, we don't know. We weren't planning to be here. Well, I can understand why you weren't planning to be here, but quite fundamentally, everybody in the community has a little bit of an anxiety about having an anaesthetic because they all know about the very low incidence of never waking up. But they all understand they're going to have a period of time where they cannot make a decision. So you can, in fact, argue that we should be doing a lot more of this, and I'll come back to that. So advanced care plan document can be a video, but we usually talk about a written document. It's a statement of wishes and values. The extent to which you do that is greater or lesser. It should include some information about decisions you may want taken or refused when you come to treatment. But if you do it on the statutory form, which is the one we are revising, it is in fact, under the Guardianship Act, the number one decision-making tool and has to be reviewed and considered before you go to the next level. The point about it is that at any other level, we talked about this a lot yesterday, the consent process then is an exchange between the clinician and whoever's making the substitute decision. They're then doing it on your behalf. The Advanced Health Directive speaks for you and is preeminent if it's there and relevant to the clinical circumstance. So I just wanted to come to this. This is just a very little bit of information that people will know. This is deaths per year in Australia. I kept asking people how many people die in Western Australia each year. It's amazing how people have no damned idea unless they take an interest in this. What do you think the number is? We've got a few votes. Any idea?
14,000.
Not bad, mate, about 15 to 16,000. About 165,000 in Australia, and obviously the numbers are going to increase because the population's been growing. But this is deaths in Australia. There has been growing across there. And not surprisingly, there are pretty equal numbers of males and females dying each year. 50% of deaths though, 50% of these deaths occur in a hospital setting. So all of us talk about where we might want to be cared for as we're approaching our last days. But in fact, I think this is probably a conservative number now. And so the hospital ends up being a critical care provider at end of life for a lot of people. Not surprisingly, if you look at the profile of the way people die, and partly because we're all living longer, most people, fortunately, die when they're older. Not surprising. But there are small numbers down here, and in fact I've now reached this age group where it's all starting to get a bit more. And a lot more, if you look at the Australian healthcare system, enormous amounts of care are being delivered to people in these three age groups, 60 to 70, 70 to 80. And it is common for them to encounter, and this is actual numbers for people dying in Western Australia. I've forgotten what year this slide was from, but as you can see here, the numbers are very small until you get up to about 55 to 60, and then there's nearly 500 people dying a year, and then steps up very quickly. And if you were to actually look at these numbers against the number of people who are alive in that cohort, then this is a very large proportion, as you could imagine, of those who are actually in that age group. So if you're getting older and you go into hospital, then there are risks in that environment, and we should be looking at a comprehensive care solution. Now, let's come to this idea then of a goals of care process and a goals of care form as being very different to an advanced health directive. And in the United States, this is called a POLST form, which stands for Physician Orders for Life-Sustaining Treatment. It is not your form. It is a form which we should develop in partnership with you. It is a plan, and the POLST form specifically is orientated around life-sustaining treatments and has come, unfortunately, a little bit too dominant in the discussion. But the point I want to make is this is not an advanced care plan, and it's not an advanced health directive. It is a form used in healthcare to plan. Now, everybody will hear about planning in healthcare. It's becoming very contemporary. If you have a chronic disease now, I've got arthritis, I've got sleep apnea, a few other things, I'm getting older, then if you have a good GP, then you will have started to develop some kind of care plan to support why you're on a medication, how often we're going to look at you, what your blood tests are, and starting to have a conversation with you about the pathway of your disease. Well, this form, developed in the United States, was all about trying to write down what the treatment decisions were with a focus on life-sustaining treatments, which has been a bit of a problem because we've struggled to get a little bit away from focusing on the life-sustaining treatments to, I think, a better conversation. But this is the origin of the form. It is a clinical instrument in hospital so that the decisions around the treatments you want, and this nasty thing about CPR comes up, and from my point of view, it's a complete obsession about hospitals. And this should be the last question, not the damn first one. If we've gone through all these discussions, no, I'm here and I want full treatment. Good. That means our primary goal is prolonging your life with all available measures. And if we agree that would be medically effective, you can't demand treatments from doctors that aren't going to work, then that will be the target. Sometimes we do that where there is a period, a trial period, where we'll provide all those treatments, and these processes, this is not like an advanced health directive, do it now and it lasts for 2 years. In our hospitals, the equivalent form that we'll come to in a minute is revised weekly. It's not static. You might choose the next level of treatment. Goal of treatment is to manage the medical conditions, avoiding burdensome measures, which is the US description. I might want some comfort treatment. I'm happy to have antibiotics and fluids, but I don't want to be on a ventilator machine in ICU. But you may use some non-invasive ventilation and so on. And you may request transfer to another hospital only if comfort needs need to be met, can't be met in the current location. So what we're doing is framing kind of the pattern of the treatment. And the great thing about this is we all know that when you go to hospital, a lot of the staff go home at 6 o'clock or 5 o'clock. If the person who had this conversation hasn't written much in the notes, you may find yourself having this conversation again on the same day, which I find profoundly disrespectful. And then you may, in fact, want only comfort treatment. And because 50% of people actually pass away in a hospital setting, this is an important discussion. And my colleagues in palliative care will say, that's great, because if you would like us to help you manage this well, then we will do. But guess what? We're also happy to give advice when you're in this one, or even in this one, because there may be palliative care elements which are important no matter what treatment level we've selected for this particular episode. And part of the important point about this is these forms have no legally binding impact. It is a clinical care plan. But if your advanced health directive sits alongside it, then it's got the power through the AHD. Most clinicians, though, recognising the new National Comprehensive Care Standard, will in fact respond appropriately to a decision-making process like this, where you've been an important partner. Now, goals of care in Australia came from a colleague that I got to know very well, Dr. Michael Ashby, who's a palliative care clinician in Tasmania. And they were the ones who originally developed this kind of approach. They call it a goals of care plan, evaluation of the patient, get the history, assess the patient's capacity. The patient has capacity, we go down this pathway. The patient has an advanced care directive, there it is again. It's influencing the process. Patient lacks capacity, can we still find this? Because they would have done it when they had capacity. If they don't have capacity, we're going to work out who is the person who's going to be standing in for you in the decision making. We're going to then discuss treatment options, likely outcomes, and what we know about patient choices. And we're going to agree the goals of care plan for this submission. This document is a decade old. Michael had a framework which would align totally with the new Comprehensive Care Standard a decade ago. And then he devised these 4 domains of care, which were very similar to the PULSE form from the US. Full curative attempts, all life-sustaining treatments, and this thing called METCALS, medical emergency responses in hospital. Something around curative care, but limiting. I'm not having it all, but the focus is on getting you better. And then something in here where there's a bit more focus on comfort care and give you treatment. If it goes well, that's great. And then one here which is totally appropriate for somebody who is actually dying. And you can see this framework has been very persistent. And then in Michael's form, and this is why we've got a very interesting outcome in Western Australia, this is where the goals of care form really comes in. Michael introduced the idea that this values discussion, the background, the information, who was involved, who agreed on the pathway, should be documented in the form. That's not on that American form. That was just the plan. And the goals of care plan brings together the information around this discussion, who was involved, how we reached the decision, with the decision around what treatments we will offer. So that's what a goals of care plan is. And that's what we're providing in Western Australia now in a substantial degree. So here is one from Tasmania. This is the goals of care plan, how it looks. And here's these categories of treatment, and here's all the boxes the clinicians tick, and here's the stuff about who was involved in the process. Now, we recently, in partnership with the Health Consumers Council and Palliative Care WA, ran a workshop around some of the elements of advanced care planning in the My Health record. We're very involved, and we've had the Health Consumers Council involved with us in this work. And we believe this fits very nicely into this wonderful framework of issues that you need to take in. I've stolen Lana's thing because I'll steal anybody's slides if I can get at them. But here's the important thing about the domain of having the conversation. The tools that we need to put in place are all important for these processes to work well. But what's not on here is what the hospital does when you get there. And so what we're offering through a goals of patient care process is a planning process in the hospital, which firstly takes into account the important elements of these tools if they're in place. And this is where I'm going to really challenge you. If only 7% of the population have an advanced care plan, and 350,000 people are going to hospital every year and 1 million people are going to ED, then let me tell you, the first occasion where these conversations occur is frequently, potentially in the hospital setting. I think a lot more of it we hope to see in primary care. If you happen to be in hospital, this may be the first occasion this kind of conversation may be valuable. So in the hospital setting, we believe absolutely in Western Australia that including the values discussion and outlining the conversation that was had on the form and preserving it is really valuable addition to the tools that are available. So we asked a whole lot of questions last time about the goals of care form, and would you want this to go to the My Health record? Well, up till now, nobody in the country's put a goals of care form into the My Health record. And when we had the seminar in here, people said to me, I don't quite get this goals of care process. What is it? Well, what it is the care plan when you're in care in a hospital or another healthcare setting. And if we've included in that discussion your values conversation, what family members were included, something about why you chose what you chose, does that sound a bit like an advanced care planning process? And that's why it is, in fact, advanced care planning information. And in the My Health record, this now goes into the section of the My Health record called Advanced Care Planning Information if the patient has capacity and requests that we put it in the My Health record. And we have now uploaded to the My Health record from Western Australia in the last few months about 500 of these documents, first in Australia. We work with the Digital Health Agency and they've created a new tab within the My Health record where you can see your advanced care planning information, and that can hold, if you put it up, your advanced health directive, your statement of values, your choices or anything else. So we're bringing together these elements, both in terms of your process and our process. So that was what we were doing with them. We had a whole lot of work going on in Western Australia around looking at it. And you can see here that the numbers are very small at the moment. We looked at the ideas around what are we going to do with this. The values conversations caught in hospital, we could see it being picked up in the aged care sector when somebody's discharged from hospital, and we're sharing the information. This is not a legally binding document. And I've got a whole bunch of doctors who are getting their knickers in a twist, quite honestly, about, but what does this mean? Well, it can't absolve you of your responsibilities to properly engage the patient and their family. And just to really come to the end of it, this new national framework being developed through the Department of Health and the new National Advanced Care Planning document, you're very privileged to see this because this isn't in the public domain, you never saw it. But it goes to this idea. All advanced care planning fits into these three elements. Having the conversation, writing up the plan or recording the plan, and then putting it somewhere where we can find it. And we believe that the goals of care process, when focused around the idea of comprehensiveness, of putting the patient at the middle of the care planning process, is important information in creating a cycle of learning. So the person who goes to hospital and says, yes, put my goals of care form in the My Health record, when you go to the GP next time, you can say, excuse me, doctor, my goals of care form is in my Health record, and I would like to talk to you about the conversation that those brave doctors at the hospital instituted that we've never had a conversation about. And we saw that as an important catalyst. But I equally hope that I will start seeing many more GPs who have initiated an advanced care planning conversation, and you'll come to me and say, my advanced care plan's in the My Health record, doctor, and I'm in the hospital, and I really want you to take it into account. So what is it? In the new form, the goals of care is a statement of the aims for a patient's medical treatment as agreed between the patient, family carers and the healthcare team. The goals of care may change over time, particularly as the patient enters the terminal phase and during end-of-life care. And I thank you very much for your attention.
Thank you very much, Simon. That was just absolutely fantastic. I'm probably all of you have seen Simon present before, but he's just wonderful.
Stop it. My head's going to swell.
So we're now going to open it up for questions. So we're going to do this two ways. So we've got our people online, and I'm going to ask them if they wouldn't mind using the chat function to ask their questions. When their questions come up, we'll see it on the screen. Simon, so either I can read them or you can read them. Totally up to you. But perhaps we start with the people in the room.
Yeah, please do.
And if you've got a question, could you please put your hand up first so that Pippa can get to you with a microphone? Because, of course, if you ask the question here, the people who are online can't hear the question, and we're also recording this session, so we need to get everything recorded. So I'll throw it open to the people in the room first. We'll get some questions and answers going here, and then we'll look at what's on the screen.
Double-barrel question, if I may, Simon. First, is there a commencement date when this process will be happening in hospitals in WA? And second, who will initiate and conduct and kind of oversee the production of this goals of care plan? Will it be an admitting doctor, a social worker, a nurse? Thanks.
Really good question. The first thing is it's actually already in place. So over the last few years, we've been replacing the traditional not for cardiopulmonary resuscitation, not for CPR forms with the goals of care form. We had a paper form, we've now got an electronic version which we're promoting. And in the background of that, this has become the standard discussion when you actually manage to have a goals of care conversation. We've recognised that goals of care conversations are much more important when somebody's older or they're very sick. And so we're now trying to promote the use of a thing called the SPIC tool, which was developed in Scotland, to really decide whether this person has a risk of not doing well or doesn't have a long time to live. And it's surprising, the SPIC tool's been very well validated. And what we're doing or moving to do now is to really increase the performance of the way people do this kind of work. And my colleague Derek Eng has just introduced a new program at Royal Perth, developed a great teaching method which he's calling ICE Remap. 60 junior doctors recently trained through that program. The feedback on that course was overwhelming. Many of them said it was the best professional development course they'd ever been allowed to access. And really our focus now is, because the machinery's in place, the forms are approved, we've now got them in an electronic format. We're moving now to, along with the national safety standards, challenge the health services to put in place means and methods of improving the quality of that work, just like we'd like to see with advanced health directives. So this is already in place. The conversation is largely held by a medico because it's orientated around the hospital treatment plan. It has to be endorsed by the senior doctor. We are, though, at the same time beginning to explore the opportunity for other health professionals to contribute. So the pathway now, if you went to Fiona Stanley, for example, is when you're admitted, they can give you a pamphlet to explain what the process is. Somebody will have made an assessment whether we think you should have one of these goals of care conversations, because for the 21-year-old who comes in having hit his thumb with a hammer, it's probably not particularly relevant, although I think it probably should be, because you're going to be anaesthetised. But for a lot more people, starting to frame the discussion around what are the influences on the decisions we're going to make around your care? Have you had that discussion with your family? We can promote that through the nursing staff who are with the patient all the time, through the junior medical officer who's now expected to fill out the early parts of the form, including, do you have an advanced health directive and all that stuff. And then at the end of it, though, we do like to close it out by having a consultant doctor endorsement. We are, though, doing some other work, particularly at Fremantle, with a colleague who is, after the patient is discharged from hospital, inviting them back to a new clinic run by nurses to actually develop an advanced care plan informed by the decisions. So we're trying to close the loop, but it's very much in its infancy. But a great question.
Simon, thank you.
Yep.
There's an online question which says, hi Simon, great presentation. Are there recommendations around training for health providers to conduct goals of patient care conversations in a patient-centred way? Yeah,
so that was really, I was talking about Derek Eng's new program, ICE Remap. Remap was a program actually developed in America around the pulsed process. Derek's picked it up. It's been picked up also by Flinders University in South Australia. But Derek's done a very nice piece around what he calls ICE, which is 3 questions. What are the important ideas at the moment? What are your concerns and what are your expectations? From my point of view, those 3 questions you should ask every patient every day. And if you're in an environment with the patient, we're talking about how you're going. What are the issues that are, what are the emerging issues for you? Do you have any particular concerns? Do we feel we've helped you to understand what you might expect from here? If you get through those 3 questions, you can start to talk about any element of a healthcare process. And the REMAP program is very much about reshaping the understanding between clinician and doctor, clinician and patient, and helps to set up a reliable system. That's why the question's an important one. Barwon Health in Victoria introduced goals of care forms quite a long time ago. We know that the quality of the forms initially will be pretty ordinary. Through a program of training, they in the end estimated that 85% of goals of care forms were of a sufficient standard to be valuable in future advanced care planning activities. So that's our goal. and I think aligns very strongly with some of the responsibilities that have been put on the system after this process with the My Life, My Choice report. Good question.
Great, thanks, Simon. Are there any other questions from the audience?
While you're all thinking, I'm going to throw a couple of other things in here because there's a couple of important other issues. Some of you may have heard of something called Choosing Wisely. Anybody heard of Choosing Wisely? Choosing Wisely is an international initiative which was started by a College of Medicine in the US, asking clinicians to think about what treatments are we providing where probably they're not valuable. But it's gone a long way from that. They've recognised that if you're offering treatments which don't improve the patient's outcome, that doesn't seem to align with the comprehensive care standard. And Australia is one of 20 countries around the world now doing Choosing Wisely. And Choosing Wisely is about understanding what works well, but also empowering the patient to ask important questions. And there are now famously the Choosing Wisely 5 questions, which are about empowering the patient to ask the clinician about what's the test, do I need it, why am I going to have it, what are the side effects, and do I really need to have it? And if you start those kind of conversations, then that leads into a consent process and an information exchange, which would also underpin quality goal setting and quality care delivery. So I encourage you, if you've not heard of Choosing Wisely, have a look at the national website. Very useful opportunity, and comes together very nicely with the new national standards.
Okay, so Simon, I don't have any questions online, so I'm just throwing it out there, people. We've not got very much long to go, but if you've got any questions, now's your opportunity. Val has got a question.
Simon, I was just wondering if you could comment on the use of goals of patient care documents outside of acute healthcare settings, so in areas like residential aged care.
Okay, so really good question and very contemporary in the era of COVID-19. I actually had some additional material which I didn't include in the talk because I felt we could go on for a long time, but there's actually been a very interesting publication about the same goals of care, goal setting process in residential aged care, where the treatment options are actually in 7 or 8 categories rather than just in the 4 that we talked about. And they go to questions like, do you want to go to hospital? If something happens to you, just want comfort care. And in fact, what we now know is that a goals of care setting process in residential aged care is highly respectful, needs to be conducted by people who are skilled at the conversation, because the person's capacity to participate will vary perhaps from day to day, or they may not have capacity. So there is very much a substitute decision maker conversation in there somewhere. So you could do a goals of care process in the residential aged care setting with a form that looks a little bit different. In fact, there's a lot of interest in that at the moment. And the Australian Digital Health Agency is very interested in whether we might actually be able to promote that work from what we've done with the hospital-based material. The other side of that coin, though, is that if you've had a goal of care form prepared in hospital, does it have value if it goes with you back to your residential aged care setting? And that, from my point of view, the treatment options do not appear to be particularly pertinent necessarily to the aged care setting. I don't know how much they do CPR in residential aged care, but the treatment discussions are a little different. And there's an important element here. This goals of care form is not legally binding, applies only to the facility. It's the care plan while you're in your current environment, and therefore it should not be considered to be an instruction when you take it to another setting. But just like the conversation of it contains important information, it should form the basis for having then a contemporary conversation in a residential aged care setting where they document what the care plan is going to be now you've returned to our care and our responsibility. This is an important area because there are a number of clinicians who are concerned that people are taking a goals of care form and giving it the status of an advanced care plan or an advanced health directive. It is clearly not that. It is not signed by a patient at the moment, though interestingly we've got 2 trials going on at the moment with a goals of care version which is patient signed, and that's particularly come up in the mental health setting. And we're interested in it, obviously in a paediatric setting, it's a bit different again. So 2 elements. what is the utility of the goals of care form prepared in the hospital when you go back to residential aged care? But I would absolutely promote the idea that it should support and promote a similar conversation around a slightly different framework in the residential aged care setting, and there's a lot of interest in doing that.
I'm going to be cheeky, Simon.
Please do.
There were a couple of maps that you had up there. Sorry?
Maps?
Okay. A couple of maps you had. Is there any chance of us getting a copy of those? That one that the guy in Tasmania developed? There was a
I'm happy to share that.
Oh, that'd be great.
I've just got to chop the slide with the new national framework has to be removed before we spread it around because it's not publicly released.
Just had some points in there. Would be
Yeah,
really
no, they're really good. I mean, that was the history of where it all started from, was Michael's work.
It's not so much a question, but it's...
Please comment.
My husband had Alzheimer's.
Yep.
In the very early stages, we saw his doctor and we did an advanced health plan. I'll get mixed up
whichever
now.
one.
And my doctor quizzed him very closely and asked him to be telling him what was in the care plan.
Mm-hmm.
And two doctors signed it.
Yep.
My husband then had an accident, fractured his hip, ended up in a pretty bad way in hospital.
Yep.
And I was informed that his recovery would be, his quality of life would be very diminished. All his values are about quality of life.
Mm-hmm.
And I had been asked at the hospital when he was first admitted, did he have an advanced care? And I said yes, so that was with all his stuff. And so I was able to have a conversation with the palliative care team.
Yep.
And they agreed that he could go into palliative care because he had Alzheimer's, he had a bit of Parkinson's, delirium.
Mm-hmm.
He is,
A wonderful description of how these things interact.
and I felt that we did what he wanted,
Mm-hmm.
and I felt that the hospital, this was Fiona Stanley, supported. He had also stopped eating.
Mm-hmm.
He made that he wasn't eating, and when they asked him would he like to eat, he said no. And he was quite with it for somebody with Alzheimer's. Yeah. So if this is implemented more, I can only just encourage people to do that.
So I think you can see, and thank you for sharing your story, and I do acknowledge the challenges you went through in that. But as you can see, if you've done that work on a preparatory basis, you can imagine that when you come to hospital and you want to document the care plan, it becomes pretty easy to say, well, we're going to choose type 4 care. And then what I didn't go to in the national standards is that not only do the standards want you to start working in this way, but in fact they also then require that you have a quality framework which you can be assessed against for the quality of the comfort and palliative care that you deliver. If the national standards are properly implemented, this will represent a profound change.
Getting back to that sort of time, as quickly as getting back to that document, what really helped me was where you said that if they didn't have the capacity, you had an arrow that went back to the advancing, and that's reaffirmed for me.
Good.
And I can tell a lot of other people of my
Yes.
friends, that if they do it now, it can help them.
That is the whole point of doing an advanced health directive when
Thank
you have
you.
capacity. And somebody else has pointed out here that they're using the goals of care form in Albany. So there's a comment here from the team down in Albany who do unbelievably high quality work, where they're already using a goals of care form in the Albany Community Hospice, which from my point of view is an obvious thing to do, and well done to all you guys. Just a comment as well, we've been working with the GP around goals of care and residential aged care in Albany, and one of the GPs down there is a colleague of mine called Jonathan Ramachandran, who's actually on the board of hospice down there, and a lot of this work's starting to stretch into that environment. What we'd like to do is now close the loop back to primary care in the community setting where you have these conversations early.
So Simon,
No other questions there.
Yep, I'm going to ask you a question now. I'm going to change roles.
Yep.
I'm interested in your comments. So when we do work in the community around advanced care planning, unfortunately we quite often get comments from participants who say something like, I went to my GP to talk about advanced care planning. He said, I'm not on the page, or you don't need to worry about that, or I'll look after you. So recognising that there is some resistance around advanced care planning, I'm wondering, I anticipate there will be equally some resistance around goals of patient care in clinical settings, and I just interested in your comments or your reflections about how we might get over some of that resistance, recognising, as you started out by saying very clearly, it's in the plans, it's in the documentation.
So in the hospital setting, I mean, 10 years ago, this was all a bit tricky, and a lot of people weren't very comfortable with the conversation. In the time that I've been at Fiona Stanley, we went from using the not for CPR form to the goals of care form. The language on the street now is about goal setting and goals of care. The culture is shifting. As I said on this one, I'm very impressed with Derek's program at Royal Perth around starting to teach junior doctors, because they need the confidence to hold these quite difficult conversations. And we also need to create a framework around the staff to support them when, it only takes one or two of these to go badly and put you off in a serious way. The issue, and I don't feel that I'm in a robust position to comment about the GP primary care setting. Haven't mentioned here, but I've done what's called a My Values statement. A colleague of mine, an intensive care doctor in Geelong, has developed a website called My Values, and it will walk you through a values conversation. If you say, I'm more interested in quality of life than length of life, you'll say, well, what does quality of life mean for you? And asks you to describe it. It then records all that information in a PDF, and in a very clever system, which I find really very interesting and slightly provocative, is it allows you to send an email to your GP and say, I have done a My Values statement, and you can read it by clicking on this link. So I think everybody who wants to start the conversation can actually lead off in the conversation by putting a My Values statement up and saying, look, for me, this is important at this time. I mean, I've got a lot of colleagues in general practice who are very focused on the partnership with the patient, and I still think that's where a lot of these conversations should start. And also, you may be in a situation where you go in with a family member who has been a little nervous about asking their GP, and you can help to promote it. Interestingly, in Victoria, if you do a My Values statement, then it can actually be taken directly up into the Victorian Advanced Health Directive to fill out the My Values section. And part of our philosophy around all this work is, why should you have to have the values conversation with 7 different people? Or if you do, let's keep adding the quality. Let's have the record of last time. Let's make it better next time. And let's not make you have to fill out the same values conversation in 7 bits of paper, because that's pretty burdensome. So Charlie's tool, you can put your My Values statement in the National My Health record under the Advanced Care Planning section. In Victoria, you can load it up into the Advanced Health Directive. I'm hoping that we'll achieve that outcome here in WA as well. But that values conversation is the platform on which you start to talk about treatment options, what to expect, and then what we would do if things don't go well or do go well.
So I'm now going to move back into my facilitative role and alert you to a couple of questions that have come up here. Involving palliative care team and hospital early can help patients have conversations about future care and have their wishes met, even if they don't have an ACP. That was from,
so we would completely agree with that. But I mean, the My Life, My Choice report, and in fact, a lot of nationally published information shows that one of the challenges in hospital is the palliative care services are overwhelmed. And so what we're really trying to do here is also implement a program of training for people to deliver palliative care services within their current clinical context. So one of our jobs under this work that we're doing now is to develop a training framework for all non-palliative care clinicians to improve the quality of palliative care support that they provide in all disciplines. The other question about the My Values thing, yes, it's a national website. It is housed in Victoria, but you can use it anywhere. You can create the PDF, you can put the My Values PDF in your My Health record. It's not restricted to Victoria. The only Victorian element at the moment which is restricted is you can't put the values statement into an Advanced Health Directive in any other state at the moment because it's not been set up that way. What I'm saying is we're hoping, out of our current processes, to look at opportunities to have you use whatever value statement to include in your Advanced Health Directive, because that's not the legally binding bit. That's the additional information. For example, in Queensland, there's a document called a Statement of Choices. Equally can go to the My Health record. The My Health record now will keep all the history of these documents and keep them in time sequence. So as you change your mind and upgrade them, then if the clinician chooses to look in the My Health record over time, they will see the history of the way your choices, your My Value Statement or your Advanced Health Directive actually changed over time. So you can use it from anywhere in Australia, and I have one as a WA person. I sent it to my GP. She said, I've never seen one of these. I said, well, that's good. Now you've learned about them. And I have put it into the My Health record. In fact, I've done it 3 times now. Along with that idea of you should seek to upgrade your statement of wishes if something changes clinically in your environment or just when you decide it's time. And we recognise that often the first conversation comes not when something happens to you, but often when something happens to a family member. When a parent passes or a partner passes, or you hear of a tragedy, a young person who dies, say from a brain hemorrhage or a motor car accident, those are the moments when often you just pause a little bit to think about, what would I want if that was actually me? The famous Perth Transit bus that lurks around this particular seminar room. No, so it's not only in Victoria.
Can I ask something else, please, Simon?
Please do.
Going back to the Advanced Health Directive, it seems clear, I think, that the form is one problem and the lack of guidance that it gives, but another perhaps for everyone out in the community is they lack the tools really to go ahead and fill in the form. Now, the material that you've put up today, the Pulse form and the Tasmanian form, seems to me that that's gold. It provides both the concepts and the terminology that many of us perhaps lack. Can there be work in the health department, do you think, in the team that's revising the AHD to build some of that into the information that's provided with the new AHD?
Well, given that's my job, I can only say yes, we'll be doing it.
Oh, that's fantastic. It'd be so helpful.
That is part of my role as the Goals of Care.
Right.
End-of-life care clinical lead is to be very involved in that work. As I said, though, a lot of the focus to date has been on the VAD implementation, a lot of work around the palliative care planning. As you know, we've just done the public consultation on the draft template for the AHD form. We learned a lot about the draft form. We will be making some major changes. But the very point about it, and if you, in the My Life, My Choice report, the parliamentarians on the committee pointed to the Queensland document, which they thought was good. Queensland just reviewed their document, thought their own document was rubbish, and pointed to the New Zealand one. I think the New Zealand one's very good, but the witnessing provisions are completely different. So, but the interesting thing is that the wheel kind of turns. As each person reviews it, it gets better. And I actually think the best one in the country at the moment is the Victorian one, which can be filled out electronically, which means it's typed. And if the damned witnessing provisions were the same as WA, you could use it as a facsimile for the Western Australian document, and I would happily test that on VICA, on the State Administrative Tribunal if we had to. But I've actually had a long look at the Victorian form, and technically, although it requires a medical officer to sign the form, if you actually had a medical officer sign the form, you would meet the requirements of the AHD. So go and look at the Victorian form. It's available online. It's able to be filled out electronically. The way it steps through the discussions around what I would want of certain treatment pathways, I think would be really interesting for me to hear back whether you find that engaging in that process. But we will not be staying with the current old version. And there's an interesting history there. When the Acts Amending Consent to Medical Treatment Act was being proposed in 2007-8, it was hanging on one vote. And the Guardianship Act is under the jurisdiction of the Attorney General. The regulations and therefore the form was all developed by the Attorney General's officers and the parliamentary draftspeople. And when we said to them, this form ain't going to work, they said, we don't care, it's going up because the Minister wants it to go up. I said, that's fine. That transition in 2008 was fundamentally important. The changes to the criminal code, which meant the doctor was no longer absolutely required to provide necessities of life to every patient, otherwise they were going to go to jail, could be charged with homicide. That transition was fundamental, but that was only 12 years ago. And we haven't yet seen the whole change of view and the greater understanding emerge. And one of the responsibilities under the reforms with the My Life, My Choice report is to improve the education for clinicians and have them understand the protections, which are actually very robust. So we will be doing a lot more, and we're really interested in, I met with the Sally Cowie at Hadsco this morning. I don't believe we're expert at consumer participation at the high level, and I'm very interested to know what information processes are going to work. We're going to have versatility. I think that a lot of it is best to focus around conditions, and we propose to do some work around, if you're a person with advanced lung disease, these are the kind of treatment decisions you're likely to face, and here's how you would think about it. There'll be general information, but if you can make it so, if you use that idea, if you can get 3 clicks to anywhere, then an electronically assisted form is likely to be very valuable. So we're very interested to have people test ideas. So if somebody wanted to go and have a little look at the Victorian form and tell me how you respond to it, I'd be really interested.
Simon, we've just got a couple more questions.
Sure.
I wonder if we could just very quickly address those because we're just about ready to finish. So have you heard of the process in New Zealand whereby every patient admitted who fits certain criteria automatically goes through an ACP process?
No, I haven't heard of that process. I'm now going to go and find out about it because that looks really interesting. I love the New Zealand form. The provisions are not nearly as restrictive. It's culturally orientated, which I really like.
And the second
The SPIC tool, it's not only for palliative care. In fact, it's a tool to actually recognise whether you want to do a goals of care planning process as an important priority. So it's used in Scotland, and we've actually been, at Royal Perth, they've been using it, but we don't think the clinicians are using it efficiently at the moment. But the idea behind the tool is, if the SPIC tool identifies that the person's frailer or at risk, then a goals of care conversation should be held during their submission because you're likely to see them again.
Beautiful. Right, I think at this stage we'll wind up. It's 5:30. Thank you so much for being a fabulously engaged audience, and thank everybody online for sharing their questions as well. But mostly thank you to Simon for being a fabulous presenter, keeping us engaged for an hour and a half. I didn't see one person looking noddy at any stage. So I think it'd be really good if we could show our appreciation to Simon again. And if I could thank you very